Good morning. Good morning and welcome to Palliative Care and Geriatrics Grand Rounds. Welcome to everyone here in the Ether Dome, all those watching from Dana-Farber, Cooley Dickinson, and Care Dimensions. I'm B.R. Dobman, the course director. It's my pleasure this morning to introduce Dr. Jeremy Abramson today. Dr. Abramson is director of the Lymphoma Program and the John and Joanne Hagler Chair in Lymphoma at the MGH Cancer Center, and assistant professor of medicine at Harvard Medical School. Dr. Abramson earned his medical degree from the Mount Sinai School of Medicine in New York City and a master's degree in medical sciences from Harvard Medical School. He completed residency in internal medicine here at MGH, followed by a fellowship in hematology and oncology at the Dana-Farber Cancer Institute. Dr. Abramson's clinical interests and research interests are in lymphoid malignancies. His research involves identifying new targets for therapy in lymphomas and lymphoid leukemias, and the design and conduct of clinical trials of new cancer therapies in these diseases. He's a member of the American Society of Hematology, the American Society of Clinical Oncology, and a fellow of the American College of Physicians. Dr. Abramson is the author of numerous papers and book chapters on lymphoma and lectures widely. I was talking with Jeremy this morning that I think this topic is the most widely retested topic that we've had for Grand Rounds this year, followed very closely by marijuana. But I think we beat out marijuana. So with that, please join me in welcoming Dr. Abramson.
Thank you. In order to make everybody happy, I will work in some discussion of marijuana if possible. Generally not such a difficult challenge, though I don't have any slides prepared about it. So I'm really honored to be here in this room, witnessed by skeletons and mummies and this august audience, to talk about a topic which has become near and dear to my heart and a primary research interest over the last 5 years, and a dominant clinical issue that's emerged over time here at Mass General and has proven to be a team sport requiring the involvement of and tremendous buy-in from numerous clinical services, including the oncology services, critical care services, neurology, palliative care, pharmacy, intensive investment by the hospital administration, and lots and lots of workings throughout the system. And so why are we so excited about CAR T-cell therapy? So I want to talk to you about that and also talk about some of the perils that come along with the new technology as we learn how to apply it to the betterment of our patients. These are my disclosures. So why do we need these treatments for B-cell lymphoma? You work with cancer patients across the cancer center, and one thing you've probably noticed is that lymphomas are among the most highly treatable of all cancers, and probably fewer lymphoma patients per capita relative to many other diseases, and particularly solid tumors, are referred for pain, symptom, and end-of-life management, though certainly many of our patients are. But the truth is though we cure about 2/3 of patients with the most common lymphoma, which is diffuse large B-cell lymphoma, that means 1/3 of those patients will not be cured. And those patients have a poor prognosis and fairly uniformly in the immediately pre-modern era would die of their disease. And that's 1/3 of over 30,000 patients diagnosed every year in the United States with diffuse large B-cell lymphoma. We also treat a number of low-grade or indolent lymphomas, follicular lymphoma, marginal zone lymphoma, chronic lymphocytic leukemia. These are diseases we think of with a natural history measured in decades. Many patients will have a completely normal life expectancy, but not all. And we do know that about 20% of patients, even with an indolent, favorable prognosis lymphoma, will still be at risk of dying of their disease. We also have lower incidence diseases like mantle cell lymphoma, which represents only about 6% of the 70,000 new cases of non-Hodgkin lymphoma diagnosed every year in the United States. And this disease, despite significant advances in therapies, remains uniformly incurable, and most patients will die of that disease as well. So across the lymphoma spectrum, we really need to do better. And though our advances have taken us a long way, including advances in conventional chemotherapies and development of immunotherapies, we need to move the bar forward. Now, immunotherapy is no stranger to lymphoma treatment. And though it has recently become the bee's knees and the cat's pajamas in solid tumor oncology with the advent of immune checkpoint inhibitors, the truth is we've been using immunotherapy in lymphoma for over 20 years. For longer than that, we've been exploring allogeneic stem cell transplant, which is really the father of immunotherapy in lymphoma. Now, stem cell transplant comes in two varieties: an autologous transplant, where we just pound patients with high doses of chemotherapy, give them back their own stem cells in order to rescue their bone marrow, or a true immunotherapy of allogeneic transplant, where we cytoreduce a patient's bone marrow, give them another patient's purified stem cells, and allow that patient's donor stem cells to regenerate a new immune system, which, because it's foreign to the patient's tumor cells, can generate a graft versus cancer effect and eradicate their underlying disease. But this technology is still, I would say, primitive. It is still using a donor immune system which isn't entirely matched to the host. It requires non-specific immune targeting, meaning you put in a donor immune system and you hope that it recognizes the patient's cancer cells as foreign and eradicates it. It primarily works only in patients who are already in remission at the time of their treatment, so it includes a large proportion of patients who have active disease and therefore are unlikely to sufficiently generate an anti-cancer response to eradicate the disease. And it includes major risks, including the need for long-term immunosuppression, risk of serious infections, including opportunistic infections, and of course the risk that the new immune system will not only recognize the patient's tumor cells as foreign, but it will recognize their healthy cells as foreign, including their liver, their skin, their bowel, and others, and that leads to the major toxicity of what we call graft versus host disease, which can be both an acute and chronic complication. And this procedure is quoted as leading to a risk of death in the 20 to 30% range, making it relatively high-risk procedure. These are average numbers. The mortality rates at the MGH Cancer Center are decidedly and markedly lower than that. But it remains high risk. Now, how about monoclonal antibodies? Rituximab is an anti-CD20-directed monoclonal antibody that was FDA approved in 1997, ushering a new era of truly targeted therapy in cancer treatment, making rituximab the truly first developed targeted therapy for cancer treatment. And what rituximab does is it can induce remissions in low-grade lymphomas. It enhances the cure rate when combined with chemotherapy in high-grade lymphomas, but it improves that cure rate by about 15 to 20%. So while a dramatic improvement, it has improved countless lives since its introduction, but it is by no means a panacea, and patients can develop resistance. It acts via antibody-dependent cell-mediated cytotoxicity, which means that you do need some preserved immune function in order for rituximab to work. Rituximab binds to cells, signals like a big flag to natural killer and T cells, but those natural killer and T cells need to be functional, recognize, and induce response. And it is a pharmacologic agent, and though a protein, it has a fixed half-life. Like any drug, it goes in and it abates over time and may require repeated infusions, and over time, it does indeed induce development of resistance through multiple mechanisms. And then more recently, I mentioned immune checkpoint inhibitors, which have become of interest in multiple solid tumors, where immune checkpoints have become dominant mechanisms for targeting. It turns out that the highest rate of responses for PD-1 inhibitors are in Hodgkin lymphoma, with the response rates over 80%. Though in the highly relapsed refractory setting, this treatment does not appear to be curing patients, nor is it curing patients with solid tumors. Furthermore, among lymphomas, PD-L1 expression is fairly heterogeneous and is not expressed in most of the most common lymphomas, including diffuse large B-cell lymphoma. And so its activity is limited to fairly niche settings in lymphoma, including Hodgkin lymphoma, as well as discrete NHL subsets, including primary mediastinal large B-cell lymphoma, EBV-associated T-cell lymphoma, and extranodal NK T-cell lymphoma nasal type, diseases that are not considered scourges in modern public health. And so why do we initially want to focus on diffuse large B-cell lymphoma? Well, I mentioned this is the most common lymphoma. There are over 30,000 cases every year in the United States, and it's also the most common lymphoma worldwide. So this truly is an international disease. While we do cure about 2/3 of patients with modern R-CHOP-based chemotherapy, about 1/3 will not respond. And our historic treatment of choice in relapsed refractory disease was high-dose chemotherapy with autologous stem cell transplantation. That treatment cured about half of patients in the pre-rituximab era, meaning before 1997 or around the turn of the millennium. However, with the introduction of rituximab and the improvement in upfront therapy, it turns out that the cure rate with second-line therapy has gone down. Because what probably has happened is a number of the patients who are cured in second-line treatment with high-dose therapy are now cured with rituximab-based therapy, and the patients relapsing after modern therapy are truly chemotherapy resistant. And we know today is that the cure rate with high-dose chemotherapy is on the order of 20% or less, a truly poor second-line therapy. And patients who are truly chemotherapy refractory have a life expectancy of less than 6 months and a chance of response to modern therapy of less than 10%. And so this is truly an unmet medical need. So it's in this context where we'd love to create a dream immunotherapy. How can we overcome some of the liabilities of our existing immunotherapies and move the bar forward? Well, we can target a novel antigen such as CD19. It's uniformly expressed on all diffuse large B-cell lymphomas and other B-cell NHLs. And it's not previously targeted with other treatments like CD20 and rituximab, so there's no de novo resistance that's been developed prior to hitting CD19. And then what if we took the patient's own T lymphocyte, not a host lymphocyte that can generate anti-host immune responses, but the patient's own T lymphocyte, genetically engineer it to go after the patient's lymphoma cells, and then populate those cells, reinfuse those cells, and have the patient's own T lymphocyte be able to induce immune response without the risk of graft versus host disease or the need for immunosuppression. Well, how might we do that? Well, what we can do is we can use a retroviral or lentiviral vector, or here a bolt of lightning. We can insert a chimeric antigen receptor, meaning a gene within that viral DNA, which encodes an anti-CD19 antibody, links it to a co-stimulatory domain, because you'll remember from your basic immunology classes that to turn on a T cell, you need a primary stimulus and co-stimulation. That's to prevent autoimmunity in all of us. And then a signaling domain called CD3 zeta that actually turns on that T cell. And what if, unlike a standard T cell receptor, which you can see highlighted here, this is a single chain region which does not require MHC presentation of tumor antigen. It can recognize the entire tumor antigen. Well, that antigen can then be expressed on the cell surface and destroy the T cell. And that's the idea behind CAR T cell therapy. And if we can do this successfully, create a cellular therapy, which unlike a pharmaceutical and unlike a monoclonal antibody, is a living drug. It does not have a fixed half-life. It is a cell that can recognize antigen, expand in vivo, and propagate itself as long as its target is present, making it a single infusion and a potentially long-term durable living drug to produce sustained immune responses. Well, this therapy became sort of widespread in social media and national press when the story of this young woman named Emily Whitehead became publicized. She was one of the first patients enrolled on a study of anti-CD9 CAR T cells at the University of Pennsylvania and Children's Hospital of Pennsylvania. She's a young woman who had twice relapsed acute lymphoblastic leukemia. She had no standard treatment options remaining. She was 5 years old, and she was one of the first patients enrolled on a novel therapy there of this anti-CD19 CAR T cell as effectively a last-ditch effort. She was in the intensive care unit at the time that she was treated. She developed rip-roaring cytokine release syndrome, did require intensive supportive care, but when the dust settled, her leukemia was in remission. That was 1, 2, 3, 4, 5. Now 6 years later, she posts every year on her Facebook page, watching her grow up cancer-free, now cured of her ALL, a remarkable story that really ushered in the power of this treatment for patients who previously had truly uniformly incurable disease. And so how do we actually execute this process? Patients go down to our transfusion center, they're leukapheresed, we collect out their nucleated cells, inclusive of their T cells. We then collect out their T cells from the other nucleated cells, where they are then transduced with the viral vector. Those transduced and now cells with a chimeric antigen receptor on their surface are populated in the laboratory. We remove the purified beads, so we now have just purified CAR T cells containing the chimeric antigen receptor on their surface. Patients receive some low-dose lymphodepleting chemotherapy, usually fludarabine cyclophosphamide, to prevent rejection of these now slightly modified autologous T cells. And those T cells are reinfused into the patient where they can exert their anti-lymphoma activity. So this started with an initial phase 1 trial of a drug that at the time was called JCAR17 and that we now call lysocabtagene maraleucel. This is an anti-CD19 CAR T cell product using a 4-1BB co-stimulatory domain. Our first patient was a patient of mine, a patient who's 67 years old, had 5 prior lines of chemotherapy. That's a lot of treatment for DLBCL, including an allogeneic stem cell transplant. Despite all that treatment, her lymphoma recurred in a soft tissue mass behind her ear, and on her immediate pre-treatment restaging scan, she also had developed a temporal lobe brain lesion. This was actually considered exclusionary from the clinical trial at the time. She did not have this lesion at the time that she was enrolled, but it took 4 weeks to manufacture her T cells, and during that 4-week period, she developed this new brain metastasis. We actually obtained special dispensation both from the sponsor and from the FDA to allow us to treat this patient, despite the fact that she now no longer met eligibility on the basis of there were no standard treatments available to treat her disease otherwise. We gave her CAR T cells, and 28 days later, she was in a complete remission, both systemically and in her central nervous system, as you can see here. Now, unfortunately, the story doesn't end with that success. She relapsed 3 months later, just behind the ear in that area that I just highlighted. We did an incisional biopsy, removed disease, and confirmed that she still had CD9 positive diffuse large B-cell lymphoma. And while we were deciding what to do next, a remarkable thing happened, which is she came in to discuss the biopsy results and talk about additional therapy. And she said, you know what, something amazing's happened. It's disappeared since the biopsy. The entire mass has gone away. And what we found when we sequenced her blood for CAR T cells is that following the biopsy of her ear, her CAR T cells re-expanded in her blood. And that would explain the fact that she suddenly experienced a spontaneous remission of her disease despite no further therapy. Now, I can't fully explain why her CAR T cells re-expanded following biopsy. Perhaps this area, which had been previously irradiated, was a bit privileged, and just the act of steel exposure allowed some exposure of her immune cells to the tumor antigen again and re-induced response. Perhaps there's something more cosmic than that. But what it highlights to me at that time in these very early days was that CAR T cells are not only a standalone treatment, but they're a living treatment that serve as a platform for further manipulation. And here we see an example of that. Just by the nature of the CAR T cells in this patient's blood, those cells could be induced to re-expand and re-exert anti-tumor response, something completely novel compared to a standard chemotherapeutic approach. And so I think this highlights this as a truly unique therapy in cancer management. We now have 3 major CAR T cell products for the treatment of diffuse large B-cell lymphoma, all of which we are using here, and I've highlighted some of the differences on this slide. We've been using primarily lysocabtagene maraleucel, the drug that I just showed you about that we used in that patient. Now, this is the only of these 3 products that isn't yet FDA approved, but MGH, we've given more of this than any other product because we've been leading the clinical development on this drug, which has now completed its registration trial for diffuse large B-cell lymphoma with anticipated FDA approval, hopefully in the late quarter of this year, probably 4th quarter of 2019. Axicabtagene ciloleucel was the first drug FDA approved for diffuse large B-cell lymphoma, while titagen lacleucel was the first one FDA approved at all, because its first approval was pediatric ALL, and it was the precursor of this drug that was given to Emily Whitehead to produce that durable remission I showed you on her Facebook posts. And so these 3 products are now available here to our patients. There are differences among them. One major difference I've alluded to already is the issue of the co-stimulation domain. Now, we mentioned T cells require co-stimulation to reduce their antigen response and activity and proliferation. But how they are co-stimulated does impact their biology, and in many senses, they're also their toxicity profile. So the first drug that's FDA approved, axicabtagene ciloleucel, under the trade name Yescarta, uses a CD28 co-stimulation domain. CD28 induces a rapid, immediate expansion of the T cells. They reach a high peak, and then they tend to abate more rapidly, as opposed to those that are stimulated with a 4-1BB co-stimulation domain, which tend to stimulate a bit more slowly, don't reach as high a peak, would have a larger area under the curve and a slower abatement. Now, one of these approaches may be better, one of them may be not. They might be two different ways to get to the same way to eradicate tumor, but they might very well lead to different toxicity profiles, and this is something we've most certainly seen in the clinic. And if you can imagine, if you have a CAR T-cell product that leads to an immediate explosive T-cell expansion, rapid release of T-cell mediated and activated cytokines, that the toxicity profile related to cytokine release might be earlier onset and higher toxicity related to a product that takes a little bit longer to get to their peak expansion and longer to abate over time. So that's something we'll think about. There are also differences in how they're manufactured. Lysocabtagene maraleucel is created using a fixed 1-to-1 ratio of CD4 and CD8 CAR T cells. And so that actually regulates how many CD4 and CD8 cells. That can implicate differences in the cytokines and the T cell milieu compared to the other two products that are administered on general T cells without subspecification. There are big differences in dosing. And so Axi-cel is weight-based, while tisagenlecleucel is administered to anywhere between 6 and 600 million cells, a large dose range. The dose ranging Elisa-cel is much more fixed at either 500,000 or 1 million, 500 or 100 million CAR T cells per patient. There are differences in how patients reach their T cells, how the lymphodepletion chemotherapy is administered, and where the treatment is administered on the inpatient versus outpatient setting. So all CAR T cells are not created equal. And so when we talk about CAR T cells, we have to think about the specific of that product in order to guide the potential ramifications for the patient. So let's think about what we are actually using and how they're working in real time. So this is axicabtagene ciloleucel, the first product that we have available for diffuse large B-cell lymphoma commercially. And I mentioned the major thing to note here is that it uses the CD28 co-stimulation domain. All three of these products use the identical CD19 binding antibody site as part of their molecule and the same CD3 zeta intracellular signaling. So the primary difference in terms of dosing and in terms of co-stimulation. The registration trial is called the ZUMA-1 trial. It included 108 patients with chemotherapy refractory DLBCL. This is defined as patients who had no response to their prior treatment or patients who'd relapsed in less than 1 year after autologous stem cell transplant. Patients had to have at least 2 prior lines of therapy, and the majority of patients had 3 or more prior lines of therapy. The mean age was 58, but there was no upper age limit, and patients as old as 76 were included in this trial. Our oldest patient is pushing 80. You can see patients had generally heavily pretreated disease. A quarter of them had a prior transplant. These are very high-risk DLBCL patients. And if we look at their response rates, and we'll focus here on the updated, most mature analysis, the overall response rate was 82%, with 42% of patients achieving a remission. And this is remarkable data, and I'll remind you, in chemotherapy refractory disease otherwise, conventional therapy has a chance of inducing remission of 6%. And so an 82% overall response and 42% CR rate is nothing short of dramatic to somebody who treats refractory large cell lymphoma for the last decade and more. But remission is one thing, and durability is, I think, more important. If this remission lasts a hot second, then we're not necessarily offering the most durable benefit to patients. I'll also note that this remission is only important if it reaches a large number of patients and not a discrete niche. And what this forest plot shows is that these responses were experienced across high-risk subset groups. And so you can see all patients straddle this line, which means regardless of their chemotherapy refractoriness, whether they've had a prior stem cell transplant, whether they received tocilizumab or corticosteroids, patients all enjoyed encouraging responses. And these are progression-free and overall survival curves. And what you can see now, with a median of over 2 years of follow-up, recently published in Lancet Oncology, is that about just under 40% of patients remain in ongoing remission after 2 years, with a plateau on this progression-free survival curve, which is fairly prolonged. And what that tells us is not only are we inducing remissions, but that we are actually curing a distinct subset of these patients. Not all, More than a third, just under 40% of these patients are cured, and that translates into a plateau rate of about 50, just over 50% of patients are alive 2 years later, a median overall survival that has not been reached at greater than 2 years, reminding you that historically we would expect a median overall survival of 6 months, which we're far surpassing with this therapy compared to what we would expect with conventional treatment. Yeah, sure. Patients in this trial all had to have a performance status of 0 to 1, up and around for greater than half the day. On the trial that we conducted with Bcell, could be 0 to 2, and there were poorer outcomes among patients with performance status of 2. On multivariable analysis, not purely related to performance status. Performance status patients are sicker. They may have more high-risk features of their disease. But certainly sicker patients are sicker going in and they have a higher risk coming in. We're looking to think about exploring performance status 2 patients more, potentially considering more pre-phase techniques to try and help improve their performance status prior to exposure. This is a tough thing because where we're looking at this treatment right now are in patients who are chemotherapy refractory. So how do you temporize a patient who's already chemotherapy refractory? Chemotherapy already isn't working. So by the time these folks have a performance status of 2, it's very hard to turn them around. I think the ultimate answer is moving this technology earlier in the course of therapy, not waiting until they're fully highly refractory and they've received 5 prior treatments, but thinking about it earlier, and we'll talk about that in a bit. Now we have to think about the toxicities of this treatment. I've alluded to cytokine release syndrome. We also see a neurologic toxicity syndrome, which we generally call CAR T-cell related encephalopathy syndrome, or CRESS. We also see prolonged cytopenias in these patients, in part reflecting the lymphodepleting fludarabine and cyclophosphamide, but also the immune milieu. We do see prolonged B-cell aplasia and hypogammaglobulinemia due to a directly on-target effect of depleting CD19 positive B cells. But notably, these toxicities are almost always reversible. Not always, and there are deaths related to this, but almost always are manageable and highly reversible. And only patients who can't weather the storm, who can't turn around and tolerate some degree of this toxicity, such as the poor performance status patients, usually do turn around. Now, cytokine release syndrome usually manifests by fever as the single presenting finding. It can then further progress and include hypotension, hypoxia, liver and kidney injury, and can include a delirium, the same type of delirium that we can see in the setting of sepsis. Management is usually with supportive care. If it's just grade 1, meaning isolated fever, this will usually turn around on its own, particularly with a 4,1-BP co-stimulated product. We can observe this, give Tylenol, and see if the patient turns around. If the patient progresses, develops hypertension, hypoxia, organ injury, we include IL-6 receptor blockade with tocilizumab. If they progress beyond that, we include corticosteroids with a high chance of turning this around fairly quickly. Now, CRS has protein manifestations throughout the body. And so, though I mentioned the most common ones, we can see extensive manifestations. We see tachycardia, we can induce arrhythmias, we can see a cytokine-mediated drop in ejection fraction. All of this is very similar. I could take away CRS and put sepsis here. And these are all the responses of the body to sepsis. This is a massive cytokine release in response to massive inflammatory cascade in the body, and that's what cytokine release syndrome is. And if we look at cytokine release, we see that the cytokine release is not uniform throughout their CAR T-cell response. And while we initially induce some immune homeostatic and chemokines, we then see a surge in inflammatory cytokines. And at these inflammatory cytokines, a lot of which is produced by macrophages and monocytes, and not directly the CAR T-cells, but rather CAR T-cell producing IL-2, IL-2 stimulating other wings of the immune response, leading to this systemic immune cascade. And it's this inflammatory cytokine release, which is listed down here: release of IL-6, IL-1 alpha, IL-1 beta, TNF alpha, TNF beta, and GM-CSF, that leads to this surge in inflammation in the body and this septic physiology. That, depending on the product, can peak either at the 1 to 2 day range with Axi-cell, or with the other products more at the 6 to 7 day range, and then abates. And that's why this is generally a self-limited process that does abate if we can support it. But we also recognize that there are some critical cytokines, including IL-2 and IL-6, which appear to stimulate the macrophage monocyte system to produce this truly a massive cytokine soup. So it might be that blocking some critical cytokines, not every single cytokine, can help abate this process. And sure enough, since IL-6 was identified early to be a potential linchpin and one of the most highest propagated cytokines in the body, we saw early on that if you administered an IL-6 receptor blocker called tocilizumab, that you can see a rapid abrogation of the cytokine release syndrome. This is a patient having neurologic symptoms of delirium, requiring 2 vasopressors, and having fever associated with CRS. The dotted line is where tocilizumab is given, and the lines on this graph represent different cytokines, IL-6, gamma interferon, and C-reactive protein in blue, orange, and green, respectively. And what you can see immediately after administration of tocilizumab, the pressors come off, the fevers immediately go away, neurologic symptoms gradually abate but not go away immediately, and the cytokines dramatically drop to 0. And this is what we see in the clinic as well, is that administration of a single dose of tocilizumab is enough to usually completely abrogate the cytokine release syndrome within the matter of hours of administration, usually in less than 2 hours. This is particularly true with lisocabtagene maraleucel and tysogen lechlucel, the 2 4-1BB products. The Axicell, the product that has the more explosive rapid onset CRS, has such an explosive cytokine storm early on that many of those patients have required actually serial doses of tocilizumab and higher doses of corticosteroids to reverse their CRS, though we haven't seen that with some of the other products. So again, the incidence, timing, and management of the CRS is a bit product specific, but I think this speaks to a really mechanistic way to treat and abrogate the syndrome early in the clinical course. Neurologic toxicity has been a bit more difficult to tease out pathophysiologically. There is some interesting data from the Hutch. We do know that it does typically occur later than cytokine release syndrome and occur in patients who previously had cytokine release syndrome, usually not exclusively. What that tells us is patients with higher cytokine levels appear to get this toxicity and occurs later. And what we think is happening is that there is this high cytokine storm is probably injuring some endothelium, and that's causing leaking in the blood-brain barrier, and that's leading to cytokine infiltration within the central nervous system, and that process takes a little more time. And so we do think that there is a direct cytokine-mediated CNS injury that is affecting, inducing this neurotoxicity, which is occurring after, usually the CAR T-cell CRS has been cresting. This has also been reversible, but interesting, tocilizumab has not actually shown response in neurologic toxicity, which is usually an encephalopathy syndrome. And that sort of stands what I showed you here, which is that the neurologic syndromes here persisted for a while after the CRS abated. What we have seen, however, is that when administration of corticosteroids, particularly with Lysocell and tysogen lechlucel, has led to rapid remission over days of this product, shows if you eliminate the cells that are producing these cytokines as the storm goes away, that we can abrogate this syndrome as well. But it's neurologic toxicity, which can lead to obtundation, it can lead to seizures, it can lead to comatose states, need for intubation for airway protection or treatment of status epilepticus, that it's in that setting that patients can really go downhill. They can get aspiration, they can get other life-threatening events. And even though this is a reversible syndrome, that if the neurotox reverses, they might not be sufficiently able to pull back and recover from the severity of illness they encountered. And so getting ahead of this syndrome is of critical importance. Again, our mainstay of treatment is corticosteroids and seizure prophylaxis, as opposed to a mechanistically directed interruption of the cytokine storm. If we look at the toxicities on the ZUMA-1 trial that I showed you, and again, this is the CD28 co-stimulation product, 93% of patients develop cytokine release syndrome, so virtually all patients develop CRS, and it was a median time to onset of 1 day, speaking to the explosive onset of a CD28 co-stimulated product. 64% of patients developed any neurologic toxicity. 28% had severe neurotoxicity, and 13% had severe cytokine release syndrome. 43% of patients required tocilizumab on this study, and about a quarter of patients required corticosteroids. So this is a high proportion of patients who required rescue medications. And because the study was happening early in the course of this, I'll tell you that in talking to colleagues who've been investigators on this trial, there was a lot of hesitancy, as we had when we started our trials as well, about giving rescue medications early in a patient's course. That giving an immune modulator or giving a corticosteroid, are you going to decrease the activity of the CAR T cells and impair the efficacy of this treatment? As one colleague said, do I really want to give this patient a 50 cents worth of dexamethasone and abrogate a $500,000 CAR T cell product that's designed to cure their lymphoma? And so there's real hesitancy to try and interrupt the CAR T cell that's been created. What we've learned since then is that while we do suppress immune function somewhat, it does not adversely affect overall outcomes. And it does not completely abrogate or deplete the CAR T cell itself. It just blunts it slightly, which does not appear to deleteriously affect efficacy. And so modern trials are actually, with this product, are using more toci and dexamethasone. Why? Because we now know it's safe and easier to get ahead of it. In this trial, more patients were getting to grade 3 in order to get rescue medications. And so it might very well be that there'd be less severe cytokine release syndrome if the study were repeated today. And wouldn't it be nice if we could predict those patients were going to develop higher rates of toxicity and have a higher chance of response? And not surprisingly, patients who have a higher CAR T cell expansion have higher rates of both response and of both neurologic toxicity and cytokine release syndrome. So what this shows is the higher your CAR T cells expand, the more toxicity you develop. I suppose that's not particularly surprising because the cells are in there doing their job, and that means there's more cells in there to exert their toxic effect. Let's think about a different product with a 4-1BB co-stimulation domain. This is Tysogen Lechlucil. This is the drug that was given to Emily Whitehead and the first drug FDA approved for ALL, subsequently for DLBCL. You can see here the same CD19 antigen binding domain, but now with a 4-1BB co-stimulation domain, potentially different disease kinetics. This is the Juliet trial. 111 subjects were accrued on this trial. Median of 56. Again, the oldest patient was 76, so some elderly patients are being treated on these studies. This study reported close to 20% of patients having a double or triple hit lymphoma. These are large cell lymphomas that have translocations of MYC and Bcl2 and or Bcl6. These are particularly high-grade lymphomas which have virtually no cure rates with modern therapy once they've relapsed. So they're a marker of particularly impossible to treat diseases with conventional therapies. These are heavily pretreated patients, with over half of patients having 3 or more prior lines of therapy. More than half of them progressed in their prior treatment, and half of them had progressed after a prior autologous stem cell transplant. So once again, these are patients in an unmet medical need. The response rate in this trial, 52%, with a CR rate of 40%. These are slightly numerically lower than the numbers on the Axicell trial, though I tell you that the progression-free survival curves look fairly similar in the rate of inducing durable remissions. Overall, this trial produced a 1-year rate of remission of just under 40%. As you can see here, the rate of progression-free survival hovers out at just about 38%, and this is a median of just about 1 year. And just as with the last trial I showed you, this plateau occurs just after close to the 6-month mark with very few relapses, suggesting if you go into remission and are there at 3 and 6 months, you are likely to be cured of your disease. If you are a patient in this 40% who achieves a complete remission rate, over 80% of those patients are in a durable remission. So achieving a CR in this treatment does appear to be highly predictive of cure if you wait long enough. And again, in this study, that was 40%. The reason there's a difference here is there is a proportion, about a quarter of patients who initially achieve a partial remission will evolve into a complete remission and have a durable response over time. So a second CAR T cell that is inducing durable remissions in highly refractory disease. Now, is there a difference in the toxicity that I showed you based on the different co-stimulation domain? Well, there's a lower rate of cytokine release syndrome, 58% compared to 93%, and it occurs later than with Bcell, 3 versus 1 day. The cytokine release syndrome as well is lower. I told you it was over 60% with Bcell. In this study, it was 21% with tisagenlecleucel, and only 12% of that was severe, and a much lower rate of rescue medication use, only 15% with tocilizumab, and only 10% of patients getting dexamethasone. So a suggestion that using a 4-1BB co-stimulated product have lower rates of CRS and neurotoxicity and lower rates of severe CRS and neurotoxicity, which is critically important. Again, thinking how can we predict who's going to develop this toxicity? What you can see, if the red bars are any grade of cytokine release syndrome, tumor volume, baseline ferritin, baseline CRP, and baseline LDH. Again, markers of tumor burden appear to be highly predictive. This is not necessarily rocket science. The more disease that you have, the more antigen you have to stimulate the T cells, the more the T cells will expand, the more cytokine storm will be produced. Interestingly, it was more predictive of CRS than of neurologic toxicities, where CRP at baseline was highly predictive, but the others crossed the axis of statistical significance. So I think we're going to have to think in a more critical way beyond just disease burden and expansion as to what might be mediating the toxicity profile. And then lisocabtagene maraleucel, again, the one that's not FDA approved, but the one we've administered the most. This is the chimeric antigen gene product using a 4-1BB co-stimulation domain. And unlike the other products, these cells are separated into their CD4 and CD8 components. They're separately transfused and then administered back to the patient in a fixed CD4 to CD8 T cell ratio. Why is this study doing it that way and the other studies are not? It's based on mice, which is why we do a lot of things early on in medical investigation, where some investigators in the lab at the Hutch said, well, if we mix CD4 and CD8 cells in different proportions, or if we give them one versus the other, do we see differences in how those cells expand? And what they found is what that in green and in most commonly in red, if you have a mix, the ratio of CD8 T cells and naive CD4 T cells, then you get a much higher expansion in the mouse model. If you then look at anti-tumor efficacy, a decreased line speaks to higher tumor efficacy. And what you can see is you get more anti-tumor response with the products that used a mixed ratio of CD4 to CD8 T cells. And if you look at survival of the mice, the red and the green curves are the curves that mix the 1-to-1 ratio of CD4s to CD8s. So you get a better expansion, better cytotoxicity, and better survival in a preclinical model. And that led to the CD4-CD8 ratio moving forward this particular product. We've been conducting what's called a seamless design pivotal trial. We started with phase 1 at 3 different dose levels, dose expanded 2 dose levels of particular interest, and then ultimately have enrolled a pivotal cohort, which is being used for FDA approval. There are 100 patients who we've already reported on in the entire data set. We can also identify 73 patients in the data set that meet the criteria of the pivotal study and are analogous to the patients treated in the pivotal studies of Bcell and tisagenlecleucel, meaning chemotherapy refractory DLBCL. And so far, 134 patients have been pheresed, 114 have been treated. Now, why is there fall off? Well, there's some fall off because 2 products could not be manufactured successfully, and we've seen this across studies. About 1% of patients cannot have their product manufactured due to their T cells not growing in the laboratory. But that means a 99% success rate, which is pretty darn good. It does mean that 18 patients didn't get their product after they were leukapheresed. Why is that? Primarily because they progressed, got too sick, or died before they could get their CAR T cells back. These are chemorefractory, sick patients. It takes 3 to 4 weeks to manufacture the cells and get them back, and that means sick patients can get sicker. And so one of the perils of this therapy, reminding us we're treating the highest risk patients, some of them will not get there and be able to get their cells even after they've been leukapheresed. Ultimately, 102 available patients across the dose levels, most of which were either a single dose of 50 million or a single dose of 100 million cells. What you can see is our median age was 61. The oldest patient we treated was 82. 20% of patients have had double hit lymphoma. We subsequently, after our index case of CNS involvement, decided to open the trial to patients with CNS disease, and now have treated more patients, still only a handful. Median of 3 prior lines and up to 8 prior treatments. The vast majority of these patients are chemotherapy refractory, and 40% have had a prior stem cell transplant, most of which were autologous. This is another one of our patients. I think pictures are worth 1,000 words, granted they're anecdotes. This is a 75-year-old gentleman, an elderly gentleman, who was initially treated for follicular lymphoma with rituximab and rituximab bendamustine at relapse, then transformed, got dose-adjusted EPOCH-R, had rapid progression despite that, received high-dose cytarabine, had rapid progression of that, and at the time of his pheresis, had disease effectively replacing his entire left hemithorax, as you can see there, having respiratory difficulties, having a disease in his retroperitoneum as well. This is normal renal and bladder uptake. He got his lisocabtagene maraleucel, and 28 days later, in a complete remission, this scan showing only his healthy brain and healthy renal collecting system. He had grade 1 cytokine release syndrome, despite a high tumor burden, and despite his advanced age, is now free of disease. He's now 9 months out, ongoing remission and likely cured of his disease. So these patients that we've treated really at a one patient level, you can look at all the data and say, boy, this is really working. When you see it with your own eyes in one of your patients, you appreciate the power of this type of therapy. In our overall patient population, our overall remission rate is 75%. Complete remission rate is 55% in the entire population. And if you look at how many patients are in a durable remission at 6 months, the answer is 40%. Intriguingly, since we looked at different dose levels, and because we separated CD8s and CD4s out, we could actually fix the dose level of CD4 and CD8 T cells. And what we see is actually we do see a dose-response relationship. And so the durable remission rate is about 50% in patients who got the 100 million dose level compared to 50 million. And that informed the decision to expand that as our pivotal dose at 100 million cells, where potentially half of patients can achieve a durable response. As with prior studies, we saw no impact of different high-risk factors, including patients with chemorefractory disease or double-hit lymphoma, on achieving durable remissions at the 6-month time point. And these are the progression-free and overall survival curves. And you can see among all patients, half of patients are in an ongoing response. If you look within the core or pivotal data set, it's close to 60%. Patients in a complete remission, not surprisingly, are doing even better than the partial response patients. And so the majority of patients, as with other studies, who achieve even if a response, remain in that response at last follow-up. 93% of patients in this study who are in remission at 6 months have remained in remission at the time of their last assessment, though the median follow-up for this study is less than 1 year, with ongoing follow-up still occurring. What about our adverse events of special interest? We've had the lowest rate of CRS and neurotoxicity across studies. Our cytokine release syndrome rate was only 37%, so it went from 93% with Axi-cel down to 50% with tisagenlecleucel, down to only a third of patients developing any cytokine release syndrome. And remarkably, with over 100 patients treated, only a single patient here, of course, did develop severe cytokine release syndrome. Every other patient on this study had only low-grade cytokine release syndrome. Now, you might be saying, is that because once everybody got CRS, they all got tocilizumab and dexamethasone, because we learned that if you get ahead of it, you can abrogate that toxicity? We've actually had a very low rate. Only 17% of patients received CRS. Only 21% of patients relieved corticosteroids. Most of those did be given at grade 2, so I do think that giving corticosteroids and tocilizumab with grade 2 CRS did prevent development of patients to severe CRS. But notably, very few patients developed any CRS, meaning 2/3 of patients had no fever, no CRS whatsoever. The rate of neurotoxicity is also lower at 23% for any patients, and only 13% of patients developing grade 3 or 4 CRS. This isn't trivial, 13% severe neurologic toxicity, showing this is a toxicity we need to evaluate. Now, I mentioned we've selected to move forward with a 100 million cell dose, the dose level 2 cell dose shown here. And interestingly, despite going from dose level 1 to dose level 2, we did not see evidence of increase in either CRS or neurologic toxicity between these two dose levels, helping to validate dose level 2 as our pivotal dose moving forward with our FDA expansion. We also are looking at potential biomarkers of response and toxicity. And what we find is if you give a higher dose level, you do get a higher CD8 CAR T cell expansion, which does seem to correlate again with a higher response rate in that group. If you look at patients who had complete remissions in blue versus no response, you can see that their CD8 cells are higher in those patients who had a durable remission, not surprisingly. And you can also see that patients who had any any neurotoxicity shown in red also had a higher CD8 CAR T cell expansion. So showing us that higher CD8 expansion is associated with higher response and also a higher risk of toxicity. The two do appear to go together, and the same thing was observed with cytokine release syndrome. We can also see this correlated with measurement of disease burden, measured based on either measurement on CAT scans or LDH, that patients with higher disease burden shown by measurements here do have a higher rate of CRS and a higher rate of neurotoxicity shown in red. We can then, I think, more intriguingly look at a biologic level and see that there are discrete cytokines that we can serve as harbingers for development of this toxicity, both before and at onset of their toxicity. And so you can see patients who develop CRS in red in both of these curves have higher rates of a number of cytokines, including CRP, IL-10, IL-16, TNF-alpha, MIP-1B. IL-15 appears to be particularly important and more so for neurotoxin CRS. And so what we might be finding is evaluating cytokine profiles are a way to help discern early who might be developing toxicity, and maybe that's who we need to intervene upon before we see development of this at a clinical syndrome, and these are clinical trials that are now developing. So one of the things I've showed you is that this is a very exciting, highly effective, but also a therapy that requires a lot of moving parts, both to manufacture, manage the patients and their toxicities. That means it takes investment from everybody, the oncology care team, the transfusion service who performs the pheresis, the cell therapy lab who processes these cells, the inpatient oncology units, and that includes nurses, pharmacists, physicians, PCAs, everybody who's caring for the patients in this intensive setting, neurologic involvement for neurotoxicity, critical care medicine for cytokine release syndrome, palliative care because the intensive surge of symptom control that accompanies these patients, as well as these are patients, remember, unlike other treatments, necessarily these are patients by definition who have advanced disease going in, meaning they already have difficult symptoms to manage from their lymphoma, and we superimpose this on top of that. Social work to deal with the protein issues surrounding this complicated therapy and the need to remain close to the hospital, multiple collaborators, both in academics and in industry, a very supportive administration at Mass General to say, this is a complicated therapy, it requires multiple resources, and it requires taking a loss early on as the nation develops. How do you figure out how to pay for something that costs $373,000 for the drug alone, let alone all the care that surrounds it? An MGH administration, and I salute Barbara as a representative of administration here as having been real leaders, I think, with us and for us in helping bring this to our patients. And Barbara has been involved in this from the get-go on London 9 before her current role. And so thinking about the next steps in the last minute, how do we actually take this and move the bar forward next? I told you early on that at the very first relapse of DLBCL, our standard treatment is high-dose chemotherapy with autologous stem cell transplant, and the cure rate, as you can see here in these modern trials, is only about 20%. That's terrible. What if we brought CAR T cells and did that instead of auto transplant? Well, we're doing that trial. We're about to activate a randomized trial. Takes patients their very first relapse. They're not chemotherapy refractory. They get randomized to go down a second-line chemotherapy route and transplant versus go directly to CAR T-cell therapy, do not pass go, and develop line after line of chemotherapy and the associated toxicities. I think the writing's on the wall, and I think this is likely to replace autologous stem cell transplant in first relapse of diffuse large B-cell lymphoma. We're also seeing promise in follicular lymphoma in early studies and in chronic lymphocytic leukemia, so we will be moving this into other diseases in the not too distant future. So I'll conclude by saying that anti-CD19 CAR T cells are transformational therapy. They're producing durable remissions in chemotherapy refractory aggressive lymphoma, which was previously incurable. We're seeing unique toxicities apart from other drugs that we've been familiarly given for years. These include a cytokine release syndrome and neurologic toxicities, which require unique approaches to identification and management, as well as prolonged impacts on their immune system, which we will continue to manage in these patients for years. These CAR T cells are already real-time for DLBCL. They're about to enter our armamentarium for multiple myeloma using anti-BCMA CAR T cell, which we've also been developing here, other B-cell leukemias and lymphomas, and we're doing clinical trials now trying to take this technology and expand it into solid tumors, which is a bit more difficult, mostly because you can target, CD19 is a great target because you can get rid of all of your healthy B cells, and the patient does fine because the B cells eventually recover and we can give back immunoglobulin. The B cell is a sacrificial cell for treatment. We've been doing that with rituximab for years. But if you've got an antigen that's shared on a lung cell and lung tissue and you give a CAR T cell and ablate all the lung tissue, obviously that won't work. So identifying a cancer-specific target with a solid tumor is a critical factor. I think we need to really move the bar forward by understanding the mechanisms of resistance, and that way we can develop better, smarter CAR technology. I think we've moved from the Model T to where we're giving the Tesla to patients right now, but we're going to develop much better CARs in the future that build on our progress to date. We're also looking at combination strategies to help mitigate development of resistance, particularly immune-mediated resistance with checkpoint inhibitors. And tandem with that, we need to understand and predict patients who are going to develop the toxicity at a biological level and seek to interrupt, interfere, and block the toxicity of CAR T cells that can be life-threatening and still preserve the benefit. That's a way to bring it to the sicker patients, bring it to the poor performance status patients, and help apply this more broadly, where right now patient selection clearly is still critical. But right now, I think remarkably, we're still at the infancy for this exciting technology. People in this room have been helping us really develop this, and for that reason, it's being given to patients across the country as an FDA-approved product, and hopefully we'll continue to advance this and bring it to more patients with fewer toxicities going forward. I want to thank you very much for your attention.
Thank you so much, Dr. Abramson, for explaining the Tesla of CAR T-cell therapies and some of the complexities that we're seeing both for symptom management and prognostication in these challenging patients. I think for the sake of time, I will pause here, and if you're willing, we'll have people come up and ask you questions afterwards. Thank you so much.
Thank you.